లెఫ్ట్ హ్యాండ్
రైట్ సార్.
చూపించు. ప్రియాప్ లేదా? నో ప్రియాప్, ఓన్లీ ఇంప్లాంట్ రిమూవల్. What is the cause for male lung deformity? Is it traumatic, non-traumatic, infective?
It can be congenital, it can be acquired. Congenital causes could be multiple hereditary exhastosis, Olier's.
Congenital or bilateral? Congenital or bilateral and multiple genetic disorders will be there in congenital. Unilateral may be traumatic, may be infective, may be metabolic like rickets, or it may be due to dysplastic. All are different. So total 5. So can you tell me the 5 causes for male lung deformity, Venkata Surya?
Trauma, infection, tumor.
Trauma, tumor,
infection.
Tumor kuda unda?
Undu.
Tumor, infection.
Genetic causes can be there.
Genetic inka? Metabolic. Dysplastic and metabolic. Yes. So what is the functional range? 17 years girl, the functional range is maintained. What about the grip strength? What about the functional activities of hand? They are impaired or improved before and after.
Yes, sir.
Clinical photograph at all, sir. Clinical photograph with the deformity, with the implant. So 6 images are very, very important. Clinical, pre-op, per-op, post-op, follow-up, videos. Can you repeat 6 points, Venkat Surya?
Clinical, pre-op, intra-op, post-op, follow-up and videos, sir.
ఫాలోఅప్ తర్వాత ఏంటి?
వీడియోస్,
క్లినికల్ వీడియోస్. ఏం చేశాను? ఎక్స్రే ఇది అది అంతే అయిపోయా. 1/2 అయిపోయా. అది కాదు ప్రజెంటేషన్. దిస్ ఈజ్ హౌ యూ హ్యావ్ ద క్లారిటీ కాన్సెప్ట్. నో సొల్లు వెండ సూత్రం వెండు ఎంత మాసేయండు మనసులాయం.
We have done implant removal, sir.
62 years.
ఖచ్చితంగా చెప్పాలి సారీ. యు ఆర్ నౌ గోయింగ్ ఫర్ ఫైనల్ ఇయర్ ఎగ్జామ్ గోయింగ్. ఏం వెంకటేశ్వర్య? ఎస్.
62 years, female with 1 month old intertrochanter fracture of left femur, sir. We have done close reduction internal fixation with sharp ear pens.
This is a 16-year male with male lung deformity of right wrist joint, sir. We have done ulnar shortening osteotomy for this, sir. Yes, sir. Post-traumatic. 2 years back, he had history of fracture, sir. He has got operated outside, sir.
ROM?
ROM is fine, sir.
All good, huh?
Yes, sir. Yes.
Palmar flexion, dorsiflexion, inversion, eversion.
Sir. For distal and radius fracture, sir.
Is it the deformity or functional inability?
What was done after operation?
That we are not sure about, sir.
Or it might have been a manipulation. Kadunda.
Yes, sir.
Yes, sir.
So what about the functional activities? Good.
Yes, sir.
So what score you have taken? Dash. Neo. Which score you have taken functional activities?
Only ROM.
Radiology here.
Radiology.
Read the radiology.
Read the radiology.
There is definitely ulnar positivity which is seen, sir.
Positive ulnar variance.
Positive ulnar variance is seen, sir. There is slight volar tilt, sir, of the distal and radius. Slight, sir. There is a dorsal subluxation of the ulna, sir.
That's all.
The radial height is normal only.
Radial inclination.
In-
Volar tilt. Ulnar variance. Radial length. 4 parameters.
What about TFCC? What about TFCC? What are the criteria to consider the wrist joint is unstable? What are the criteria to consider the wrist joint is unstable? Is it stable? Wrist joint unstable? No, this picture is stable.
Allotability is
Sir? Yes, sir.
Okay, what is restored now?
We have only reduced the length of the radius, sir. So that he is having only pain over the ulnar side of the wrist joint, sir. Yes, sir. There is no radial pain, sir. That is why.
So what about the radial ulnar
It is there, sir. It is there, sir.
armor flexion?
Yes, sir. Yes, sir.
All movements?
Yes, sir.
Grip strength is good.
Hip strength is also good, sir.
Very good, excellent. Yeah, thanks.
75 years male with intercrustaceous fracture of right femur, sir. We have done hemiarthroplasty of right hip joint, AMP prosthesis.
This is a 21-year-old male with compound grade 3B. This is a 21-year-old male with compound grade 3B MTB joint dislocation of the third toe and the base of the proximal phalanx, fracture of third toe and fracture of the head of the fourth metatarsal, sir. This case came to our casualty at 11:45, sir. We have operated it in the morning 7 o'clock only, sir. K-wire fixation. Yes, sir. Sir, here is a fracture, sir. Head of the fourth metatarsal. Here
Third.
and base of proximal phalanx is also there, sir.
X-ray లో కనిపిస్తుంది. EPT లో కనిపిస్తుంది.
Yes, sir. MTP, sir.
Third MPT.
We have done K-wire fixation for third as well as fourth. We fix the head, sir.
Why at 4 a.m., why not in the morning? It is such a life-threatening emergency.
7, sir. 7.
Could have fully done in the morning. 4 a.m., everybody will be tired.
Sir, 7 a.m.
7 a.m. sir.
7.
Plantar only, sir. Yes, sir. From the anterior aspect of the toes we have passed, sir. From the front of the toes we have passed. Yes. Yes, sir.
Straight through the terminal phalanx into the metatarsal.
We can use the web space even, sir. We can use the web space even.
Was it difficult to pass the K-wire straight in the first attempt through and through all the challenges and metatarsal?
We have taken 2 attempts, sir. With CM also.
2 attempts is very good. It's not that easy to pass through the center of the challenges.
Yes.
Technically a little difficult. Yeah, of course. Even with Siam, not that easy.
There is one secret is there, sir. There is one secret.
చెప్పు
Secret చెప్పాలి.
సీక్రెట్ అంటున్నాం మళ్ళీ చెప్పు
చెప్పాలి మరి చెప్పకపోతే వీళ్ళందరికీ అర్థం కాదు. వీళ్ళకి తెలుసు
సీక్రెట్ అనకూడదు
దాని సీక్రెట్ ఓపెన్ సీక్రెట్ ఆల్రెడీ కాదు. So actually you got a nutrient foramen. So you can't pass somewhere else. You have to pass through the nutrient foramen entry point. Whether licit or for the dose and the metacarpal, metatarsus. Metacarpals are there, metatarsals are there. So that is the entry point. You should know that entry point. Then only you can go next. If you go somewhere else, it goes somewhere else. You will be in great trouble. Great trouble. That is secret point. Okay, next.
This is a 80-year-old male with
Take the bone. You can see. You have noticed that point.
Yes.
Yeah, very good, excellent.
80 years old male with intertrochanteric fracture of right femur. This is Borden Griffith, grade 4, sir. We have done a close reduction internal fixation with long PFN, sir.
Very long PFN.
Subtrochanteric extension.
Stable, unstable fracture.
Unstable, sir.
What are the criteria to say it's unstable fracture?
If it is only,
What are the criteria to say it is an unstable fracture?
if it is a two-part fracture, it is stable. Rest all are unstable, sir.
The medial cord is intact or medial cord is broken, comminuted, reverse oblique.
Not reverse.
Ego classification, ego classification.
Medial column is very, very important. Medial column.
Yes.
If it is broken, it is very unstable. And sometimes they may need plate augmentation.
Yes.
Give additional support. Otherwise, the implant may cut to the bone very osteoporosis. Because the adductor force is so great.
Yes, sir.
Adductors of the hip.
The patient is 8 years old, hospital
Continuous deforming force. Next. Plate will counteract the adductor force.
23 years male with 1 year old post-op case of compound grade 2 comminuted supracondylar fracture of right femur with implant failures. He was operated elsewhere, sir. We have done open reduction internal fixation with
Status.
sir.
They are not
Non-united, sir.
they are united or
Non-united, sir.
what is the range of movements?
Flexion,
Was it infected? Healed by primary infection in the beginning?
moments,
Much of information. Not simple.
flexion up to 30 days.
Post-op. Pre-op it was
Pre-op.
0 degrees, sir. He was not able to flex only, sir.
ROM is one. Whether there was any history of infection.
No issue.
No,
of
no
infection.
history of infections.
These 2 points are very important. Why the fracture has been
He is able to walk, sir. Yes, sir.
Yes, sir.
bearing weight
He is bearing weight,
Bearing
sir.
weight, sir.
with pain.
With pain. Actually, they have used the wrong plate, sir. This is the right femur, sir. They have used the
Left.
They have used it wrong or right. Discuss it. Is it non-union? That is what you should.
Yes, sir.
1 year old, the non-union, delayed union, what type of union? Infected
Sometimes
non-union?
it
What
can
Delayed.
still walk with some rigid and fibrous non-union.
Yes, sir. Pain.
So implant is a wrong side implant.
wrong side implant.
Wrong side.
Yes, that is an important point.
Mode of injury is RTS, sir.
Both, sir. Both are there, sir. At least 15 holes, sir.
Actually, there is one calculation for transverse fracture. To the fracture, transverse fracture length, the length of the plate should be 3 to 4 times bigger. For long spiral, for long oblique fracture, it should be 8 to 12 times bigger than the fracture length. That is the principle. That's how you have calculated. So that scientific reason is very, very important. I'll do like this, he will do like this. They will do like this. That is different.
It's non-union. Non-union, sir.
They are superimposed. Do not know whether it is united or not. Laterally
It's non-united.
most of it is covered by the plate.
Plate.
So an oblique view will give a better information.
Yes, yes, sir. 30 degrees.
See, patella is far distal usually. At the level of the knee joint.
Pacha.
Baja.
Baja.
Vaha. J is
Osteoporotic.
These are the components of fracture disease present here. What are the components of fracture disease? What are the components of fracture disease?
ఈ topics ఉన్నాయి. We have to rush through some. No discussion. Not much of discussion unless it is relevant.
Yes, sir.
This is a 37-year-old female with close comminuted supracondylar fracture of left femur with intra-articular extension with Hoffa fracture, sir. These are the CTP images, sir. Medial, sir, medial. So we have done open reduction internal fixation with dual plating for left femur, sir. Intraopic, sir. The 34-year-old male with AC joint dislocation of right shoulder, sir. We have done open reduction internal fixation with double endo button, sir. K-wire is also there, sir, yes.
What is Bosworth procedure? Bosworth. That is endometriation procedure. Anchoring. Coracoid to the clavicle.
Or I was not there, sir.
Yes, sir. Senior, sir.
It has gone upwards, sir. No fracture, sir.
What is the classification for AC joint?
Rockwood.
So which type?
How many types are there?
Total 6 types are there, sir.
This is which type?
Vertical mode or horizontal mode, that's what you want to fix it.
Yes.
So the endo button is not left.
Okay.
So you need to fix the AC joint also or not?
Yes, sir.
Right? So you have already fixed the endo button with the clavicle to the profile. There is knee? Yes, there is knee. Otherwise, this is up again. That's it done.
Plan is to remove the K-wire after how many days?
After 4 weeks at least. A 68-year-old male with intertrochanteric fracture of left femur and 6 months old post-op follow-up case of intertrochanteric fracture of right femur with implant in situ, sir. We have done close reduction internal fixation with proximal femoral line, sir.
Sir, these are cases done in Unit 3. 36-year-old male with a closed middle third shaft fracture of left humerus. We have done ORF with plating for left humerus. Anterior, sir. Plate is anterior, sir. Anteromedial, sir. Sir? No, no, sir. Plate is the anteromedial, sir. No, sir.
These are, sir.
18-year-old male with grade 2 compound middle third shaft fracture of right tibia. We have done CRF with island for right tibia. Rim, sir. Rim, sir. So grade 2, sir. Grade 2, sir.
Open fracture means twice ring or ring.
On rim, sir.
Always something is one.
Wound is sterile, no contamination.
No, sir.
Wound
Se-
is closed, debridement done.
Wound.
yes, sir.
Close the wound or take open?
Sir, grade 2, sir. Open one.
After surgery, did you close it or close?
Yes, sir. Close, sir. With stay sutures.
At least for a few days we should not close it. It is clean, no discharge.
How many days now?
Post of 4 days, sir.
Did you see the wound again? No infection?
Yes, sir.
No, clean.
Yes, sir. Clean, sir. No
No
discharge.
spike, nothing.
Nothing, sir.
Patient is happy.
Yes, sir.
After a week or so, it is clean. And delayed primary surgery,
Yes, sir.
so the bone doesn't get exposed.
70-year-old male with 1-month-old distal third tibia fracture with and bimalleolar fracture. So external fixator applied somewhere else, sir.
Was it a open fracture?
Huh?
Was it a open fracture?
No, sir. It's a segmental fracture at that time.
Sir, is it a final fracture or not?
No, sir.
No. Where the fracture shown?
Medial malleolus.
So tibia fracture here, medial malleolus and lateral malleolus.
Medial malleolus. Still it is displaced. Medial malleolus was opened or closed?
Close, sir. Close, sir.
Closed.
Yes, sir. Posterior malleolus intact, sir. Yes, sir.
So where is the rational here? The rational to fibula.
हाँ sir, fibula.
Fibula fracture. First leg is not. Initial leg is not there.
No, sir. I have done CRF with island for tibia and open reduction internal fixation with plating for medial malleolus. Yes, sir. Not possible.
Varus or wireless? Leg. Right side is opened up.
Fracture is angulated. Medial cortex opened up.
Yes, sir.
Medial. Lateral angulation. Not medial. Lateral angulation.
There is gap in the fracture or not?
How many months old that X-ray?
1 month. Yes, sir. So,
First thesis.
thesis also.
Thesis topics. First
ఇద్దరివి లేవు సార్.
Good morning, sir. Sir, thesis topic to study the functional outcome of trimalleolar fracture treated with posterior lateral approach. Introduction of the of the study. The annual incidence of ankle fracture is between 108 to 187 cases per 1 lakh patients. Trimalleolar fracture usually affect young men and older women. Incidence of trimalleolar fracture is 13 to 20 cases per 1 lakh patients. Incidence of posterior malleolar fracture is between 26 to 80 cases per 1 lakh patient. When posterior malleolus is laterally displaced, then it is very difficult to approach through medial, lateral and posterior medial approaches. If we do the through direct posterior approach, then complications like injury to neurovascular bundle occurs. Posterior lateral approach advantage of addressing the fibula fracture. All ankle fractures are not treated with posterior lateral approach. Sir. No, sir. Aim of the study to assess the functional outcome of surgically treated trimalleolar fracture by using posterior lateral approach.
You have to add one more sentence. The trimalleolar means medial malleolus is also one of the important components.
Okay,
How you are going to address the medial malleolus also has to be addressed there. Then it gives a complete picture of how you are going to manage. For lateral malleolus, this is an approach for addressing posterior malleolar fracture as well as lateral malleolar fracture, which is not feasible with the true lateral approach. That is the point that we should highlight in this. So, medial malleolar fracture needs necessarily an approach, a classical approach to the medial malleolus. Otherwise, we are not mentioning about the management of medial malleolus. That sentence has to be added. Then it gives a complete
okay, sir.
you have to refine that.
Okay. Objectives of the study. Primary objective to study the functional outcome analysis of fixation of trimalleolar fracture using the posterior lateral approach. Secondary objective to obtain good to excellent radiological and functional outcome using the posterior lateral approach of trimalleolar fracture.
Any difference in between the two? Both are same.
You can put the objective.
Okay.
Secondary objective should be you are following it up. You are having some arthritis changes. What you are doing for those cases. That objective you can add.
So writing. Okay, sir. Pen. Review of the literature. A study conducted by J. Mingo Robinet. The posterolateral approach offers numerous advantages, such as a single incision to approach both fractures in the fibula and the tibia, the possibility of performing a direct and anatomical reduction, and increase the coverage of soft tissue. Methodology. Study type: prospective study. Study setting: SVS Medical College Hospital. Study population: patient undergoing surgery for trimallar fractures through posterolateral approach in SVS Medical College Hospital. Sample size: 15 to 20 patients, calculated using open AP software. Watch. Sample technique: patient having trimallar fracture according to Log-Hansen classification. Study period: 2 years. Data collection tool.
Sample size should be finite. It's not some range of 15 to 20. There is a formula for sample size and it should be definite. 20 patients is 20 patients.
Study variables: demographic variables, age, gender, BMI, pre-existing medical conditions, injury categories, mechanism of injury, type of trimallar fracture, Log-Hansen classification, associated soft tissue injuries, treatment variables, type of posterolateral approaches used, timing of surgery, implant type and fixation method, functional outcome measures, range of movements, pain score, weight bearing status, functional score, time to return for daily activities.
There is something called AOFAR score. Put an active score. All this is like basic. What is the functional outcome for trimallar fractures? Go and read in the literature and use the same score.
Radiographical assessment: X-ray angle, anterior-posterior and lateral view, mortise view, CT scan of trimallar fractures.
You have to make lots of spelling mistakes. You have to correct.
Inclusion criteria.
Use a red line in the typing. You have to be conscious of that.
Okay.
It is red line, spelling mistake. If it is a green line, grammatical. Do you know that?
Red line.
Yes, sir.
Red line. Inclusion criteria: patient's age between 18 to 60 years, trimallar fracture where posterior fragment is lateral or posterior, all closed fractures. Exclusion criteria: compound trimallar fracture, patient having neuropathy with uncontrolled diabetes, associated neurological deficit, open trimallar fractures.
What is the difference between compound trimallar and open trimallar?
Sir.
See, you're doing a thesis, you should do something new.
Okay.
Or you should compare to standard protocol. Okay?
Okay.
This is already the standard of treatment for all closed trimallar fractures. What new are you doing? Nothing. Okay? When there is no thesis topic like functional results, it's a comparative study or it's an observational study or it's a case cohort or a case control or a cohort. What you are doing, you should write that method in your title. Okay? Everything will not come functional results, then it doesn't make any sense. What is the nature of your study should be coming in the thesis topic, whether it's an observational or it's a retrospective.
Sir. Sir.
Okay, so you have to modify your topic, do something new, which is you are comparing two standard of treatments. This is already the standard of treatment for trimallar. Always having that in your mind. What new are you contributing to the existing literature?
Not it. No, sir.
Which
Jairam.
కొన్ని కరెక్షన్స్ చేసి మళ్ళీ అప్డేట్ చేసి చూపెట్టాలి.
Good morning, sir. My topic is comparative analysis of functional outcome of open reduction and internal fixation versus primary arthrodesis in management of Lisfranc injuries.
Lisfranc injuries ఎన్ని వస్తాయి స్టడీ పీరియడ్లో?
Pardon me?
అవుతాయి ఆ కేసులు? నాట్ ఏ కామన్ ఇంజరీ.
About 12 cases. 12 cases can get in a training of 2 years.
2-3 years దగ్గర వీళ్ళు స్టార్ట్ చేసేటప్పటికి 6 నెలలు పైన అవుతుంది.
2 years can collect at least 10.
ఫైనల్ ఇయర్లో అక్టోబర్లో ఎగ్జామ్ అయితే డిసెంబర్లోనే సబ్మిట్ చేయాలి. గట్టిగా చూస్తే 1.5 years కూడా ఉంటుంది.
Comparative, sir. Sir, Jairam, sir. Introduction. Lisfranc injuries involving disruption of tarsometatarsal joints are increasingly reported due to rising road traffic accidents, sport injuries, and industrial trauma in India. Timely and appropriate management is crucial to prevent chronic pain, deformity, and arthritis. The two main surgical options are open reduction and internal fixation, primary arthrodesis, that is fusion of involved joints. Need for study. Indian patients differ in occupation, often manual labor, barefoot, walking habits, and in injury patterns. Regional data will guide orthopedic surgeons in tailoring Lisfranc treatment protocols. Socio-economic factors like affordability, time of work necessitate evidence-based cost-effective choices. Aims and objectives. Primary aim is to compare the clinical and functional outcomes of open reduction internal fixation and primary arthrodesis in Lisfranc injuries in an Indian population. Objectives: to compare radiological outcomes post-operatively, to evaluate time to weight bearing and return to activities, to assess complications like arthritis, implant failure, or need for revision of surgery, to assess cost effectiveness and impact on quality life. Classification used for grading of Lisfranc fractures will be Quenu and Kuss classification and Meyerson classification. This is Quenu and Kuss classification. There are 3 patterns of injury. First is homolateral in which laterally 4 metatarsals are displaced. Isolated, in which the medial metatarsal is only displaced. And divergent, in which both medial metatarsal along with all 4 lateral metatarsals are displaced. Another classification is Mearson classification. It is divided into type A, type B. Criteria. Chart. Okay, sir. Yes, sir. Criteria, inclusion criteria, age 18 to 65 years, acute Lisfranc injury, isolated Lisfranc injuries. Exclusion criteria, polytrauma, diabetic neuropathy or peripheral vascular disease, chronic Lisfranc injuries. Materials of the study, study design, prospective comparative study, study setting, Department of Orthopedics, SVS Medical College and Hospital. Study duration from July 2025 to December 2026. Sample size approximately 20 patients. No, sir. Okay, sir. References. Okay, sir. Okay, sir. Thank you, sir. Yes, sir. Thank you, sir.
Good morning, sir. My topic is prospective study on functional outcome of dual plating for isolated distal femur fracture, sir. Introduction. Fractures within 15 centimeters from articular surface of distal femur, that is between articular surface and junction of metaphysis to femoral diaphysis, are defined as distal femoral fractures, which constitute around 5 to 6% of femoral fractures, sir. These fractures are frequently associated with high velocity trauma, comminution, soft tissue injury, instability and articular surface extension. An additional support of distal femur fracture stabilization by using double plating technique similar to that used in two column fractures of acetabulum, distal humerus and tibial plateau fractures has been done in this study. Aim of the study is to evaluate the functional outcomes of double plating in the management of isolated distal femur fractures over a prospective study period at SVS Medical College, sir, and hospital. Objectives of the study is to assess the most common patterns of distal femur fractures treated with double plating, to assess post-operative functional outcomes using standardized scoring systems, that is NEAT score, to evaluate radiological union and alignment following double plating through serial imaging, sir, to estimate average time required for patients to regain pre-injury functional status. Methodology, study setting, Department of Orthopedics in SVS Medical College and Hospital, who satisfy the inclusion criteria. Study design is prospective observational study. Sample size is around 30 cases, sir. Study period is over 24 months from the time of approval. All the patients who satisfy inclusion criteria shall undergo undergo baseline demographic data collection, pre-op X-ray and serial post-op X-rays, data entry. My inclusion criteria is patients between 20 to 50 years of age, fractures less than 2 weeks, compound grade 1 fractures, Muller's type A2, A3 and type C1, C2 and C3 distal femur fractures, patients who are fit for surgery, patients who are willing to give informed consent. My exclusion criteria is age less than 20 years and more than 50 years, compound grade 2 and grade 3 fractures, Muller type 1, type A1, type B1, B2, B3 distal femur fractures associated with distal neurovascular deficit, and systemic conditions such as osteoarthritis, malignancy and immunocompromised states.
Inclusion criteria, last 2 points have no relevance.
Sir?
This is fit for surgery only, you take it
Okay,
for
okay,
surgery and other.
sir. Yeah, I'll correct it, sir.
You give consent only, you will okay.
But need for dual plating, there will need for all plating. Dual plating, why have to chosen dual plating? Need of stability.
For stability.
Weight which aspects on single plate, they are problem. Problem is that weight which is one side. Not some more failure. So since have a dual plating to the bundle and of sugar is more, but that's not the idea. Just plating, putting lateral plating and use. So there is many failure. Weight is there, common in just think avoid these things. You have selected this as a topic to discuss. Dual plating. These are studies, why dual plating is not
Is it for all the cases of distal femur fractures, dual plating, irrespective of the fracture pattern, or is there any specific indication?
No, sir. Intra-articular and comminuted fractures.
Okay.
ఏజ్ కూడా
Sir.
50 పెంచండి.
Okay, sir.
The medial column is intact,
Sir.
there is no comminution. That itself gives a stability and prevents collapse.
Okay, sir.
It is not mandatory that all distal femur fractures need to be fixed with dual
Certain type of fractures that result in failure, those are selected.
medial column is the main criteria.
Okay, sir.
There is no comminution in the cortex. It is adequately stable.
Okay, sir.
So osteoarthritis, stimulus, already include your
Okay, sir. Chest, sir. Okay.
You can include open injuries also.
Okay, sir.
Open grade 1 and not open
Grade 2 and grade 3. So I'll correct, sir.
grade 2 to this,
Okay, sir. I'll add, sir.
factor C1, C2.
Sir. Chest. Chest.
Put the numbers and then put.
Yes, sir. Sir. Yes, sir.
Age 18 to 70 years.
All
Okay,
are
sir.
refined presentation in the next Thursday. Meanwhile,
Dual plating is mainly to give rotational stability.
Okay, sir.
Then only you rise. Because the distal end of femur is trapezoid in construct. So LCP is almost outdated. Now they are going for variable angle locking okay, to give better anatomical reduction, articular congruity, early rehabilitation, better functional results. So that anatomy varies with the distal femur, especially in adults.
Okay,
So that configuration is very important. So adi chapali. So when is there so your selection there itself goes way swings off. Yeah, sir. Yeah, sir. Same Sridhar. Yeah, variable locking. That is the reason why they are coming with variable locking. So not in all cases we advise a dual plating. So to give rotational stability and articular congruity and early rehabilitation. So that is the motto. Otherwise they will end up in trouble.
Expected outcome, sir. Compared to single lateral plating, double plating is expected to reduce mechanical complications such as varus collapse, malalignment, and non-union. Due to stable fixation, early weight bearing and physiotherapy are expected, leading to faster recovery. If there is positive outcome, double plating can be used as effective treatment modality for comminuted distal femur fractures, especially in high demand and or high risk cases, sir.
rear plating with a rigid construct. What is the end pressure? Non-union. Compound to single lateral pressure. Expected outcomes are
Compared to single lateral plating, double plating is expected to reduce mechanical complications such as varus collapse, malalignment, and non-union.
non-union. So if you go for rigid construct, you go into a non-union. So
Okay.
should be a stable construct. So it's better coming with the variable blocking compression. So it is basically rear plating basically to prevent rotational deformation forces.
This slide is irrelevant for your thesis. Okay? You have to give an introduction. What is the need of the study? It's a review of literature, materials and methods. What materials you are using, what is the method of the study, and what statistical analysis, how you are doing.
Okay, sir.
Functional scores, what you are taking, and radiological analysis, how you are calculating the union, and how much follow-up you are doing. That is relevant for you. All these expected outcomes nobody wants.
Okay,
We know what are the outcomes. We want to know what you are getting out of the study.
Okay, sir.
References.
So that pattern has to be followed by every individual who's presenting the thesis.
Okay, sir. I'll cut that.
Show the references. References. That is very, very important.
లైబ్రరీకి వెళ్ళి సెర్చ్ చేయాలి ప్రీవియస్
Okay, sir. Just
టాపిక్స్
చేస్తాను.
indications, actual indications ఏంటి dual plating. You all distal femur fractures require, you put a question, then it will give all the articles related to that in the library.
Okay, sir.
You have access to all journals in the library. If you are go through the library,
No, sir.
that is where you have to search, not the internet here.
Yes, sir. Yes, sir.
ఎవరు సెర్చ్ చేయడం కాదు, కాలేజీ లైబ్రరీకి వెళ్ళి సెర్చ్ చేయాలి.
Yes, sir.
సెర్చ్ చేయండి అందరూ.
Yes, sir.
హోల్ వీక్ ఇదే పని మీకు. నెక్స్ట్ వీక్ రిఫైన్డ్ ప్రజెంటేషన్ తీసుకురావాలి.
Okay, sir.
దట్ విల్ బి ఫైనల్.
Okay.
So you should have evidence-based articles.
And you have a previous thesis topic done by your seniors, you can also pick up from that.
Okay,
Your
sir.
job will be made much more easier.
Okay, sir.
Soft copies. Soft copies, you get the framework.
Yes, sir.
Jubilee. అంత బోల్డ్ పెట్టకూడదు టైటిల్, ఇది ఓన్లీ ప్రజెంటేషన్. బోల్డ్ లెటర్స్ పెట్టకూడదు.
Good morning, sir. My topic for thesis is comparison of functional outcomes following early and delayed orthoscopic repair for traumatic and non-traumatic rotator cuff injuries. Rotator cuff injuries is a common condition causing shoulder pain and dysfunction, especially among older adults. Causes include intrinsic tendon degeneration and extrinsic trauma. Although both conservative management and surgery are commonly used for rotator cuff injuries, there is ongoing debate about the ideal timing for surgical intervention. In particular, it's unclear whether early repairs offer better functional outcomes than the delayed surgeries. The aim of this is to evaluate whether early, that is less than 3 months post-injury versus the delayed greater than 3 months, orthoscopic repair affects functional outcomes, range of motion, pain levels and retear rates in the patients with traumatic and non-traumatic rotator cuff injuries. So, study design is prospective cohort study. To divide the groups, it is by the cause, traumatic versus non-traumatic, and by timing, early repair versus delayed, less than 3 months and greater than 3 months. Outcomes measured are shoulder pain, range of movements and retear rates. Follow-up duration is minimum of 6 months to 10 months. Sample size is 25. Inclusion criteria include patients with full thickness rotator cuff tears, who underwent orthoscopic rotator cuff repair and minimum post-op follow-up of 6 months. Exclusion criteria includes partial thickness states, revision rotator cuff surgeries, incomplete clinical data or loss of follow-up, degenerative conditions also. Investigations are MRI to confirm diagnosis and detect post-op retears and clinical evaluation. Surgical reports, imaging findings and post-op follow-up data used for the analysis. So. Exclusions. Yes. Like.
So that is called multi-directional instability of the shoulder blade. Any rotator cuff injury more than 3 months old, even you try to do it, is less predictive.
Sir, you are talking about instability. This is a cuff tear, sir.
And a cuff tear,
This is
sir.
different.
Yeah. If
So
it is a cuff tear
there are
more
two
than 3
groups.
months, you said that partial tears are excluded, only complete tear. More than 3 months old, what happens?
So there are too many groups here. Okay, you can't compare traumatic versus degenerative or non-traumatic that you have taken. So you just take traumatic group, conservative versus early repair versus delayed repair. Take that group only. That is enough. If you take too many variables, then your analysis will become a big mess.
Sports injuries are different entity. Another point. It's all very important.
To identify.
Sir was telling you include in exclusion criteria irreparable tears anything more than 4 centimeter. All those will be excluded. Okay. And having associated stiffness, changes of adhesive capsulitis, all these will be excluded. You should have a free range of motion with a cuff tear. That's it.
Yes. Expected outcome to identify differences in post-operative outcomes between traumatic and non-traumatic rotator cuff tears, to establish whether early surgical intervention leads to better functional recovery and reduced pain, to guide post-operative rehabilitation protocols tailored to the type and timing of the injury, to support individualized surgical planning based on the injury etiology and chronicity, to identify, to highlight differences in outcomes between traumatic and non-traumatic rotator cuff injuries, to promote evidence-based prioritization in surgical scheduling, to explore the long-term functional outcomes. These are my references, sir.
This slide doesn't have any value. What expected outcome you have to do. Only those 4 topics we need.
Good morning, sir. My thesis topic is about the functional outcome of complete AC joint dislocation repair using double endo button technique. AC joint dislocation is common in contact sports and road traffic accidents. Rockwood type 3 to 6 injuries are typically unstable. Traditional repair methods have high failure rates due to poor stabilization. Double endo button technique offers anatomic corticoclavicular stabilization with minimal invasiveness. Need for study. High incidence of chronic pain and dysfunction in untreated or improperly managed AC joint injuries. Need for a minimally invasive, stable and functional superior technique. Limited data on long-term functional outcome using double endo button technique to evaluate patient recovery, satisfaction and shoulder function post-operatively. Aims and objectives. Aim is to evaluate the functional outcome of complete AC joint dislocation repair using double endo button technique. Objective is to assess the post-operative shoulder stability and function using constant Murley score. To evaluate time to return to activity or work, and to access the radiological maintenance of reduction, and to analyze the complication rates like implant failure and redislocation. AO classification of AC joint dislocation. Inclusion and exclusion criteria. Inclusion criteria includes age from 18 to 60 years. Rockwood type classification from 3 to 6 injuries. Duration injuries less than 6 weeks and informed consent. Exclusion criteria and chronic dislocation for more than 6 weeks. Open injuries are open fractures and pre-existing shoulder pathologies, neurological deficit in affected limb. Materials and methods. Study design is prospective clinical study and sample size is 12 patients, sir. And duration is from January 2025 to December 2027. And surgical technique. Arthroscopically assisted double endo button technique repair using a tight rope system. Follow up at 6 weeks and 3 months and 6 months. Evaluation tools. Sir? Okay. Okay, sir. Okay, sir. తీసేసా సార్ పాయింట్ evaluation tools, constant Morley score and visualization analog score and radiographs. References, and these are my references, sir. Thank you.
Anything recent 2020?
No, sir.
2007, 13, 14. No 2020 series. Latest board gives the, that is also one of the drawback. That's what Ross Ekram says. Your references have the points of value.
Sir?
We can see only the author name and the journal name. There is a topic, what's the bonus. There is something called Vancouver format. Follow that.
If you see the end of any chapter, the pattern how the references are given, you have to follow the earlier teacher have done that. It is recommended to use only mention the name of the
Okay, sir.
What is Vancouver style?
Topic name and author name. Yeah, topic name and author name.
That's all. Clinical and subjective evaluations are very, very important. Clinical and subjective. Clinical and symptoms. Subjective అంటే డాక్టర్ అనాలిసిస్. పేషెంట్ ఎస్ అంటే డాక్టర్ ఎస్ అనాలి. పేషెంట్ నో అంటే డాక్టర్ నో అనాలి. ఆయన ఎస్ నో అనుకో. మిస్ మ్యాచ్ నాట్ యాక్సెప్టబుల్. సూక్ష్మంలో మోక్షం.
Good morning, sir. Today, my thesis topic is comparative surgical and functional outcomes of robotic versus conventional total knee replacements. Introduction. Total knee arthroplasty is widely accepted treatment for advanced osteoarthritis. Robotic assisted TKA is an emerging technology offering potential precision and advantages. The study compares functional and surgical outcomes of robotic versus conventional total knee arthroplasty. Need for study. Increased demand for precision in the joint alignment to evaluate if robotic TKA offers better short-term and long-term results. Lack of region-specific comparative data. Aims and objectives. Primary aim to compare surgical and functional outcomes between robotic and conventional total knee arthroplasty. Objectives. Assess intraoperative accuracy and complication rates. Evaluate post-operative alignment. Compare functional outcomes using standardized scoring systems. Review of literature. Studies suggested improved implant positioning with robotic systems, conflicting evidence on superiority of functional outcomes, and limited long-term comparative studies.
Can you show the studies? Studies giving improved implant positioning. Any author? Any journal? That is review, no? Not just three statements.
Materials and methods. Study design. Prospective comparative study. Sample size 30 patients, 15 in each group. Inclusion criteria. Patients with primary osteoarthritis undergoing total knee arthroplasty. Exclusion criteria. Inflammatory arthritis, previous knee surgery and infection. Grouping and procedure. Group A robotic assisted TKA and Group B conventional jig based TKA. Same surgeon and implant used for all procedures. Surgical parameters compared. Operative time, intraoperative blood loss, length of hospital stay. Functional outcome measures. Visual analog scale for pain,
knee society score, range of motion, timed up and go test. Follow up and assessment. Post-op evaluations at 2 weeks, 6 weeks, 3 months and 6 months. Standardized radiographs. Functional assessment via validated scores. Expected results. It's hypothesized. Robotic TKA have better alignment accuracy, lower early post-operative pain, comparable or better functional outcomes in early follow-up. Limitations. Learning curve for robotic surgery, cost and availability, short follow-up period for long-term complications. Timeline study duration 18 to 24 months.
It's very superficial. There is no detail in your study, what you're comparing, what alignment you're talking, what scores you're taking. Very, very superficial. I know what time crunch you have taken it from some AI in a generated tool, but you put your brains also into it and increase the depth of the value in the studies.
Okay. The study aims to provide clarity on whether robotic TKA offers meaningful advantages over conventional methods in real-world settings.
Real world setting, AI.
Good morning, sir. My thesis topic is functional outcome in genuvalgum operated with distal femur osteotomy. Introduction, sir. Genuvalgum is a coronal plane deformity affecting knee biomechanics. If untreated, it leads to abnormal gait, patellofemoral instability, and early osteoarthritis. Distal femoral osteotomy is a joint preserving surgery indicated in skeletal mature patient with genuvalgums. Need for the surgery. Limited data on post-operative functional outcome in Indian population. Early identification and surgical correction improves quality of life, helps guide surgical planning and rehabilitation protocols. Background, sir. Genuvalgum may be idiopathic or secondary to trauma, rickets or skeletal dysplasia. Lateral distal femoral angle deviation contributes significantly. Distal femoral osteotomy realigns mechanical axis and delays arthroplasty. Aims and objectives. Aim to evaluate functional outcome in patients with genuvalgum treated with distal femoral osteotomies. Objectives: to assess pre and post operative mechanical axis deviation, to evaluate functional improvement with standard knee scoring system, Holmes and Coos, to monitor radiological healing and comparative post-operative surgery. Inclusion and exclusion criteria. Inclusion criteria: patient aged 16 to 40 years, clinical and radiological genuvalgum, undergoing medial closing or lateral medial closing or lateral opening wedge distal femoral osteotomy. Exclusion criteria: skeletal immaturity, inflammatory arthritis, previous knee surgeries, post-infective or post-traumatic deformities. Material. Material and methods. Study design, prospective observational study, sample size 10 to 15 patients estimated. Okay. Yes, sir. Duration 1.5 to 2 years. Yes. Okay. Assessment tools, radiographs, standing long leg alignment views, sir, and scoring knee injury and osteoarthritis outcome score, visual analog scale, sir. Follow up 3, 6, 12 months, sir.
The scores you have taken are the knee instability scores. They don't have any relevance with the deformity correction surgery.
Okay.
Change your scoring systems.
Okay.
Radiographs and how you are going to evaluate in the follow-up, your follow-up criteria has to be defined.
Okay.
It's very much incomplete.
Okay.
Good morning, sir. Today's my thesis presentation is about prospective study on functional outcome of biplane double supported screw fixation in intracapsular fracture of femurs. Adults. Introduction is intracapsular fractures. Intracapsular fracture. Intracapsular fractures of neck of femur are common, especially in elderly osteoporotic patients and in young adults. Introduction. Intracapsular fractures of neck of femur are common, especially in elderly osteoporotic patients and in young adults following high energy trauma. Preserving the femoral head with stable internal fixation is desirable in physiologically young patients to maintain hip function. Conventional fixation techniques such as cannulated cancellous screws are associated with complications like varus collapse, cutout, and non-union, especially in osteoporotic bone. Biplane double supported screw fixation technique offers biomechanical advantages by using two oblique planes with cortical support, enhancing stability and reducing complications. This is review of literature. Aims and objectives. Aims include to evaluate the functional and radiological outcomes of biplane double supported screw fixation in the management of intracapsular fracture of femur. Objectives are to assess the rate of fracture union and complications like non-union avascular necrosis, to evaluate functional outcomes using Harris hip score, to analyze the effect of patient age, bone quality, and fracture types on outcomes. Methodology includes study design is prospective observational study. Study group, patients aged more than or equal to 18 years diagnosed with intracapsular fracture of neck of femur and treated with BDSF technique. Study duration is 1.5 years and sample size is 12.
Osteoporosis, how you got it? Osteoporosis. Include BMD.
Okay.
All patients should have BMD.
Okay.
We have BMD, so include BMD.
Okay. Inclusion criteria is patient aged more than or equal to 18 years with fresh closed intracapsular fracture of femoral neck, patients fit for surgery and consenting for BDSF. Exclusion criteria are pathological fractures, patient with neglected fractures, patient medically unfit for surgery, and with pre-existing ipsilateral hip pathology or arthroplasty.
Consent for BDSF. The patient going to understand what is BDF, what is CC. That is not relevant. You just have to say only internal fixation, not replacement.
Also the upper limit of age you have tried. You can't of the same thing to 70 year old.
Okay.
That's the exclusion criteria.
But if more than,
Physiologically they are
yeah, I think upper limit will be decided on the amount of displacement and the physiological age. So you can say upper limit, age limit, because nowadays we can fix at 90 provided it's undisplaced. They are physically good health. So there's no upper age limit as such.
Study implementation process, clinical and radiological diagnosis, post-operative evaluation and counseling, surgical fixation with BDSF as described by Filippo, post-operative rehabilitation and follow-up at intervals 6 weeks, 3 months and 6 months, clinical and radiological assessment during follow-up. Study variables, age, sex, fracture pattern, union status, time to union, Harris hip score at follow-up, and complications like non-union, avascular necrosis and implant failure.
Yeah, minimum 2 years. I Rajshekar. I'm sure I'll introduce you.
Study period is 18 months, right? So your follow-up can't end at 6 months. So it needs to be 1 year.
Because, yeah, that's it.
Data collection methods are patient history and clinical examination, radiological evaluation, X-rays, pre-op and post-op, follow-up, functional assessment, Harris hip score, and data entry into pre-designed performer. Statistical analysis, descriptive statistics, mean, standard deviation, frequency, comparison of categorical variables with chi-square test, and p-value is less than 0.05. Thank you, sir.
That I think, see, thesis should be, you should be able to finish the study in 1 year.
Okay.
Next 6 months, you should be able to write up. And it should not be, because if you put 3 years follow-up, it will be 1 year follow-up or 18 months. 1 year. 1 year minimum, 1 year follow-up.
Okay.
So by the time you finish, probably everybody will. So you should be able to finish within first year of your course. Yeah, you can say data collected prospectively.
Okay, sir. Thank you.
So modify, once guides are allotted, you modify, sitting this is, and today I think you have to submit to the principal office. Tomorrow, when is the last? Tomorrow.
Good morning, sir. My topic is functional outcome of long proximal femoral nail versus short proximal femoral nail in intertrochanteric fractures in elder patients. Introduction. Intertrochanteric fractures are more common in elderly patients due to osteoporosis and low trauma energy. So the most preferred treatment is surgical stabilization with proximal femoral nailing, which is standard method. The need for study is a rising incidence of intertrochanteric fractures in the aging population, as well lack of consensus on superiority between long and short proximal femoral nails. Need for comparative data on functional outcomes, complications and recovery. The aims and objects are, main aim is to compare functional outcome between long proximal femoral nail and short proximal femoral nail in elderly patients with intertrochanteric fractures. The objectives for the aim is to assess the operative duration, blood loss and hospital stay, and to compare post-operative complications and to evaluate the functional outcome by using Harris hip scores.
Oh, this was done recently? Any of the, did you check whether the study is done?
Yes, not done.
Not done. Not only is it submitted, if it's submitted in last 3 years,
Not.
it won't be accepted. Did you check that one?
Yes, sir. I checked.
On the website?
Yes. The methodology is, the study design is a prospective comparative study, and the sample size is 30 patients, 15 in each group, and the study duration is 18 months. Follow-up period was 6 months minimum, and the data collection is done like intraoperative, post-op, clinical evaluation and radiographs. Functional assessment tool by using the Harris hip score. The AVO class. Okay.
But you can have more number of cases. You have to, whatever you're submitting should be bare minimum, but by the time you submit your thesis, you can always have more number of cases. You cannot have less number of cases.
Okay. This is the AVO classification for the intertrochanteric fracture. The inclusion criteria is the patient aged more than 60 years and radiologically confirmed intertrochanteric fractures where the
Why more than 60?
like it's more
Why did you choose more than 60?
more common in elder patients like
60 probably. Will you get less than 60 here? I think age, I think probably a lower age limit need not be 60. You can reduce to maybe 40.
Okay.
40 also.
Okay. And operated with either short or long PFN, unable to provide informed consent and follow-up. The exclusion criteria: pathological fractures, polytrauma patients, and fractures extending into the subtrochanteric region, and patients with neurological or cognitive disorders affecting rehabilitation. And the mid. Okay. Okay.
Yeah, and you select only isolated fractures.
Yes.
If it is bilateral, will you include or not?
Not
You have to think about that.
Okay.
But any fracture, not only polytrauma, as the sir said, fracture on the same limb.
Okay. And the materials of the studies: implants, long PFN and short PFN from the same manufacturer, and the instruments: standard orthopedic surgical set, fluoroscope, radiological assessment, X-rays pre and post-op, and the scoring system we are using is Harris Hip score. And the statistical analysis software is the SSPS equivalent. And these are the reference.
I think you need modification. Go back to your title again. The next one. How you are going to include in both groups? How you select the patients?
So randomly selecting.
How you are going to randomize? That you have to know. You won't be knowing, but you have to know.
Okay.
There are various methods of randomization.
Okay.
And you have to take the consent
Okay.
with the patient that we will be using either. You also including that one
Okay.
in consenting. Do you know which is a simple randomization method?
Yes.
So if you take 40 patients, make 20 each, put in a box. Every time patient comes, take one chit out. That's also randomization.
Yes.
But you can, various modern randomizations are there. You generate a number. Probably you have to sit with the statistician,
Okay.
then decide. But you have to explain to the patient.
Yes.
And ethical issues, you have to justify that both are acceptable. We just okay. Next one.
Thank you.
Done.
Vishal?
Okay. Whatever.
Journal, sir.
Okay. Also get training in how to use computers.
Yes.
And you must remove your beard.
Okay, sir.
No beards in orthopedics.
मुझे नहीं पता रे किधर है.
Because hair contamination is the commonest source of infection. They carry a lot of. Which bacteria hair carries? Root follicle. What bacteria? Anybody?
कौन सा है देखो इसमें.
Any senior resident? What bacteria? What is the normal commensal of the skin? Epidermidis. And what is the common cause of infection? Periprosthetic fracture or any infection? Epidermidis. So your own commensal becomes pathogen. What? Weird. So next Thursday there will be a barber outside. You will certify. We'll call hospital barber. Sridhar. You tell hospital. Patient barber. You will sit there outside. I think they have to.
मेरे इसमें ग्रुप है रे भाई ग्रुप था क्या
Probably, really, if it is by religion, they have to produce a certificate. By religion, you are no. Okay. Otherwise, we will follow Tirupati rule. Barber we won't be able to have time to shave everything. You will shave a little bit of it, so the remaining you will do it yourself. What happened? Did you check whether it's going to be?
Yes,
did you check?
In the starting we checked, sir, it went off.
Okay. Go on.
Good morning, sir. Today my journal topic is for greater trochanter versus pyriform fossa entry nails for femur shaft fractures. This is the abstract, sir. It's an online journal.
Why did you choose online journal? Easy to. What did you say? JBJS or one of those? Why did you choose this one? Who did you ask? Anybody? Yeah, it was. Huh? It's not online. It is published, but it was interesting. I know. You're asking him. That publication, Elseover.
Yes, sir.
Same publication as JBJS.
Okay, sir.
One of the popular publishers.
Introduction. Fractures of femur shaft. Most common injuries associated with polytrauma and life-threatening occur in a bimodal distribution. High energy trauma in young population. Low energy trauma in elderly population associated with other comorbs necessitating a thorough advanced trauma life support, assessment and interdisciplinary care. Description of intervention. Most femoral shaft fractures are treated surgically. Early surgical stabilization is associated with a reduction of complications and mortality. Intramedullary nailing is currently considered the gold standard for treatment of femoral shaft fractures. Early definitive fixation within 24 to 48 hours reduces the incidence of pulmonary complications, infection rates and mortality. Advantages of intramedullary nailing: short hospital stay, rapid union, early functional use of the limb, early weight bearing that helps maintain muscle mass, functional strength and mobility. The insertion site of intramedullary nail is outside the zone of injury, preserving the surrounding blood flow and retains the hematoma that contains beneficial bone growth factors. Pyriform is entry. Entry point is just medial to the tip of greater trochanter. In certain cases, the greater trochanter may be curved and medialized. It is necessary to ream through the medial tip of the greater trochanter. The nail trajectory is along the long axis of the femur and a straight design nail is used in this. And trochanteric entry. For long nails, the incision and the entry point lies somewhat posteriorly along the anatomical axis of the femur. The anterior and lateral bow of the nail accommodates the curvature of the femur. And the research question is GT entry for antegrade femur nailing superior to that of pyriformis for the shaft femurs fractures in adults? The superiority of one entry point over the other outcome parameters included are operative time, exposure to fluoroscopy and malunions, non-unions, abductor weakness, varus malalignment and Harris-Hipp scores. Materials and methods. This systematic review was performed and reported according to the preferred reporting items for systematic review and meta-analysis. The databases are PubMed, Embase and Scopus, and 3 reviewers. Data extraction. Data extracted were collected and registered under baseline characteristics. Name of the authors, year of publishing, type of study and the fracture type of nails. Use demographic parameters like age, sex, number of patients, mean follow-up time, operative and fluoroscopic times, delayed malunions, and postoperative complications, varus malalignment, functional outcomes. And this is identification. Record identified through electronic database search. PubMed is 100 and Embase is 97 and Scopus is 114. Total records are 311. Excluded duplicates are 295. Studies screened are 16 and studies excluded by title and abstract are 4. Full text studies assessed for eligibility are 12. Studies excluded is 4. Not in English is 1 and no full text available is 1 and review articles are 2. And citation tracking is 1. Included full text studies are 9. Inclusion criteria: femur shaft fractures, intramedullary nailing with piriformis entry or greatotrochanteric entry, and age should be 16 years or older. And exclusion criteria is intra-articular and intertrochanteric femur fractures. Results: the 9 studies were included between 2011 and 2017. In those, 5 prospective studies and 4 retrospective studies. Mean follow-up period is 15 months and 7 studies were used in the meta-analysis. Operative time: 5 studies reported on duration of surgery. The average duration of surgery in GT group is 67.7 minutes, whereas in PE group it is like 85 minutes. On meta-analysis, the duration of surgeries in piriformis group was significantly higher, and exposure to fluoroscopy. 3 studies reported on the exposure to fluoroscopy during the surgeries. GT group is 100 minutes and in piriformis group it's 152. Seconds. These results favor the GT entry, suggesting it to be technically simpler than the PE entry. Delayed union: 9 cases in GT group and 10 in PE group. No significant difference was seen in both the groups. Non-union: 4 studies reported on the incidence of non-unions, 1 in GT and 6 in piriformis group. On meta-analysis, the incidence was more in PE group. Varus malalignment: 2 studies reported on varus malalignment, 9 in the GT group and 2 in the PE group. The meta-analysis favors PE group with lesser incidence of malalignment, but authors considered inclusion of proximal fractures as the factor responsible for more varus, along with the designs of the nails they used. Therefore, varus malalignment, which is serious complication with GT entry nails in intertrochanteric or subtrochanteric femur fractures, may not be such a big issue in shaft femur fractures. Abductor weakness or Trendelenburg gait: 2 studies have assessed this parameter. 9 cases in the PE group, while none of the patients in the GT group were affected. The meta-analysis confirmed higher rates of abductor issues in PE group. And functional outcomes: Harris Hip score is the tool used in 3 studies to demonstrate the functional outcome differences between the 2 groups. And Harris Hip score in PE group was 80, while in GT it was 84. This is very important parameter favoring GT entry nails. And discussion: piriformis fossa is anatomically aligned with the femoral shaft long axis, which aids in insertion of straight antegrade intramedullary nails through this entry. On the other side, the GT tip is lateral to the long axis, which requires the nail to have either malleability or an approximate angle of 6 degrees proximally for the entrance into the canal. GT entry provides better rotational stability and theoretically avoids intracapsular infections, iatrogenic neck of femur fractures, and femoral head devascularization, which are reported in PE nails. It has been reported to be technically simpler, especially in very obese patients. Piriformis entry: nails usually required unavoidable surgical dissection through the hip abductors and external rotators, thereby leading to more soft tissue damage and trochanteric nails than the trochanteric nails. Additionally, higher incidence of iatrogenic injury to medial circumflex femoral artery and superior gluteal nerve have been reported with piriformis fossa entry. GT entry nails require shorter surgical time, and the exposure to intraoperative fluoroscopy was also found to be significantly lesser than PE group. The present study establishes that the fact that GT entry nails are superior to that of the piriformis nails, with shorter duration of surgery requiring lesser radiation exposure, lesser damage to musculature, and better functional outcomes. Varus collapse and issues with union are non-significant difference between the 2 groups. And conclusion: intramedullary nails are the treatment of choice for femur shaft fractures in adults. Greatotrochanteric tip is simpler and better alternative to the conventional piriformis fossa for antegrade entry point of these nails, as it provides better functional outcome and has shorter learning the criticisms. I thought it was an online journal. So.
Injury is one of the oldest
Yes.
journals. Very.
Duration
So
of
all printed journals are available online.
yes, sir.
But all online are not printed journals.
Yes. Duration of study was from 2011 to 2017, and it is published in 2019. It is relatively an old study. Systematic review study overall includes 5 retrospective studies and 4 prospective studies. Total number of subjects is 9.
Any heterogenic neck femur fractures in the history?
Yes, sir.
Heterogenic neck femur fractures.
I never saw. Sir.
You have not mentioned.
No, sir.
But I think it's a good study, and it's very simplifies.
Yes.
And technically, I think it's superior. I mean, in the sense technical advice. But you can't use all the nails.
Yes.
You have to have the design of the nail so that.
Gamma nails and cephalomedullary nails.
Every company will give their operative guide.
Yes.
In that they will mention it.
Sir, in this it is mentioned in piriformis fossa nailing, avian changes can be seen, but that never happened here, sir.
In the possibility.
Avian changes aite an unnayi, sir. Yes, sir. Follow up lo naithe avian changes eppudu chudale, sir.
But we do not have any, we not published any. So that I think that is a good indication to follow up and do the study, analyze our own patients. No, whatever retrospective. But we can, yes, we should have.
Give the entry point is easier.
Yes.
Yes.
Whereas you have to
Struggle with, yes. You are
And
right.
obese patients, it's more difficult.
And this,
keep on
the one we
repeatedly
use
poking.
is a entry point very pump. Sure.
Two points are easy entry, and then less chance of vascular complication and radiation time.
So there is long PFN is there, recon nail is there, metadone is there. What is the difference?
Yes, sir.
Long PFN is there, metadone is there, recon nail is there. What is the difference?
I think Rajshekhar, Dr. Rajshekhar is professor, joined as a professor, and he will be in unitary. Okay, he's got vast experience, especially in trauma. So he will take classes and joined from today.
Thank you, sir.
Yeah. Been done?
Yes, sir, done, sir. సార్ మీరు చెప్పారు సార్ ఎందుకు లాస్ట్లో ఎందుకు సార్
క్యాచ్ చేసావు పాయింట్ ఇక్కడ నువ్వు కూడా క్యాచ్ చేసావా దట్ ఈస్ వెరీ ఇంపార్టెంట్ వాట్ ఈస్ ద రీకాన్ నైట్ వాట్ ఈస్ గడ్డని చూపించబట్టే గడ్డాలు అందరు కుదిపెట్టాలి గడ్డాలకి అందరు లైన్లో కుదిపెడతాం నో గడ్డాస్ నో గడ్డమ్స్ అందరినీ కుదిపెడతాం ఓ గడ్డమ్స్ అందరు గడ్డాలకన్నీ కుదిపెడతాం మహాలక్ష్మి ఇద్దరు
నేను తర్వాత రేపు మాట్లాడుతాను. చూసుకో సార్, చెక్ చేసుకో, సిస్టమ్ ఆఫ్ చేసి
lakhs for different CD and those rates for DHS. They used to charge